As we all know, this is my disclosure regarding to this topic. As we all know, ACL injury every year we see more than more ever, and increasingly we see lots of patients with their injured ACLs, and we are trying to treat them as our in the best way we can. Of course, we still should consider conservative treatment for ACL injuries, like in older age with lower activity level patients, and also if the patients have good subjective findings, but objective findings are bad, but the subjective findings of the patients are good. However, the role of the exercise to prevent osteoarthritis is not still clear. But we all know that, according to the literature, the delay of surgery between 90 days to 1 year over 40 years of age does not increase the risk of meniscus injury. However, a delay of over 1 year increases the risks, especially at the medial meniscus. The patients can lose their medial meniscus. So, according to the literature, we know that delayed ACL reconstruction has worse outcomes. Also, osteoarthritis following ACL injury, if you look to the meta-analysis, the osteoarthritis of the non-operative patients a little bit higher than the operated ones. Or the patients who can have total knee arthroplasty are higher in the patients who did not have any ACL surgery, who were treated conservatively. So, the real prognostic factor is the concomitant injuries that we see with the ACL. Chronic instability like neglected ACL injury or inadequate surgery or re-injury that needs revision with the recurrent episodes of instability at the patients causes meniscus and cartilage damages. That means it begins early osteoarthritis in the knee. So don't forget, ACL is not itself only a reason of pain. ACL is a reason of instability. If the patient with a neglected ACL injury has pain, then we should think about the concomitant injuries like meniscal tears or cartilage degeneration or cartilage losses. So the prognosis, the concomitant injuries are important. Patients with pain and chronic instability, if you see a patient like this, always we should check the opposite knee for if there is a malalignment in this knee, or also is there a constitutional virus in the other knee too. So we should, or we may add proximal tibial osteotomy in our ACL reconstruction or revision cases. If there is cartilage damage in the medial compartment, if there is a loss of meniscus volume, or the patient had a partial meniscectomy or subtotal meniscectomy, let's think, or he has an irreparable meniscal injury, and if the ACL deficient knee has a higher varus deformity than when we compare to the intact knee, then we should consider about performing an HTO combined with the ACL surgery. Else, one ends up with a stable but painful knee. So varus alignment may cause a failure of ACL reconstruction. So we should consider osteotomies. What are the indications for combined surgeries of HTO and ACL reconstruction or revision? Medial compartment osteoarthritis with varus alignment and ACL injury, or failed ACL injury, neglected or failed ACL injury, or varus alignment with ACL injury, and the patient has meniscal injury and medial compartment arthrosis or double triple varus alignment too. What are the contraindications? Of course, three-compartmental arthrosis, highly decreased range of less than 100 degrees, or high grade of cartilage damage in the medial compartment. What are the relative contraindications? High grade patellofemoral arthrosis that we can, it's important, the examination of the patient is important. If the patient has radiologically patellofemoral arthrosis, however, in the examination, he doesn't have any patellofemoral pain, then it's a relative contraindication, or we can find another solution like resurfacing the patellofemoral joint. The patient over 60 is a relative contraindication, but the activity level of the patient is more important than his or her age. So smoking for osteotomy, if you consider osteotomy, you should consider if the patient is smoking or not. And the obesity is another relative contraindication too. So when H2O alone, when H2O combined with ACL reconstruction or revision, if the main symptom is pain, then with varus alignment, then we should consider the H2O. If the main symptom is instability but no pain, so if there is not more than 6 or 7 degrees of varus, then we can consider only ACL surgery. If the patient has a higher level of activity, then we should consider with ACL reconstruction and H2O. If the patient's activity level is low, then we can perform only H2O alone. So let's talk about a case. This is a 30 years old male who had 10 years ago an ACL reconstruction. You see a vertical tunnels. Also, of course, it failed soon, and he didn't have any operation more. But now he has you see the medial compartment arthrosis with recurrent swellings, effusions, and he has a lot of pain. So how we perform this surgery? First, the first incision with the longitudinal incision, not the oblique one, we perform the ACL harvest, graft harvesting. I use only all inside technique. So only ST semitendinosus graft is enough for me, like 25, 26 centimeters. I can get a 8.5 or 9 millimeters of graft. If it is thinner than 8 or less, then I can get gracilis too. So after getting the ACL graft, then I perform the femoral tunnel, anatomic femoral tunnel at the footprint according to the size of my graft. So I use the all inside technique for the femur too. At the femur, after opening the femoral tunnel, I postpone opening the tibial tunnel and go directly to osteotomy. Maybe you can perform your osteotomy a little bit in the distal part, but doing after performing my osteotomy, I don't put the anterior screw of the plate because I will put a tibial tunnel there. So I after opening the tibial tunnel and fixing my ACL reconstruction or revision, my graft, then I can put the anterior screw without harming my graft. The all inside technique is a very advantageous technique with short grafts, thick grafts, and also preventing the harm of the graft. So you see how I open my tibial tunnel, anatomic tibial tunnel according to the footprint. Then you see how I pass my screw. So you can convergent, divergent, change your angle. But you have a short tunnel here, so it's a socket. So your graft doesn't interfere with your screw. That's a big advantage. So I replaced the new ACL revision in my revision case. So this is the post-operative X-rays and orthoröntgenograms. This is the 10th week. You can see this patient got weight after not performing any sports with his swelling knees. Now he can give weight because he can exercise very well. So take-home messages: neglected ACL injuries or failure of ACL reconstructions may lead to osteoarthritis. Don't forget. Be careful about malalignment in patients with pain and chronic instability, and please consider combined ACL surgery, reconstruction or revision with HDO simultaneously. Thank you very much for your patience.